Hi, my name's Becky. I work for BHA Leeds Skyline, and we're a HIV support and prevention service working in the Leeds area. I wanted to do this training. We've got World AIDS Day coming up on the 1st of December, and I just sort of wanted to let people know about HIV and how it is today. So, what we're covering today. So we're going to look at what is HIV and how it's transmitted, facts and figures. I'm going to compare it to Leeds, what's going on in Leeds as compared to the UK and globally. We're going to look at HIV prevention, what tools are out there, testing, who needs to be tested, how often and where to get tested, HIV support, so kind of what we do and what you can be doing, to support either HIV positive people or prevention or just general HIV causes as well. So what is HIV? Now, at its real basic level, we've got it standing for human immunodeficiency virus. Now, most people out there have heard of HIV. It's not unknown to a lot of people, but what a lot of people don't know is how it affects the world. So if you think of HIV, you might think of some of these things, that it is just a virus. I mean, we're all used to seeing pictures of little viruses floating around in our systems, from COVID. You might think of gay and bisexual men. You might think it's an African virus, And when you think of HIV, you might think of AIDS. So HIV is all of those things. But although it does disproportionately affect some communities, we do know it disproportionately affects men who have sex with men and African communities. It doesn't actually discriminate. It can affect any human in the world. It can affect all genders, sexualities. Everyone has the potential to contract HIV. I've just put some keywords at the bottom there if you're not sure about what immunodeficiency means. So we can't always talk about HIV without talking about AIDS. Now, for a lot of people, HIV and AIDS are just very closely linked, very interconnected, but they are two different things. So AIDS stands for Acquired Immunodeficiency Syndrome. Now, AIDS came along before they knew what HIV was. This year marks 40 years since the very first official AIDS diagnosis back in 1981. And it took a couple of years longer before scientists were able to discover that it was HIV causing people to have these symptoms and these problems. So if you leave HIV untreated, it destroys a person's immune system, so they get aggressive, opportunistic infections. And that's what they die from. Nobody dies from HIV, nobody dies from AIDS. It destroys and damages the immune system, and they die from those infections that the lowered immune system has caused them to get. So in this country and other countries, AIDS is not officially used in medical settings. However, as I'm sure you're aware, and most people are aware, it is still used. People still use it. And in some communities, HIV and AIDS are interchangeable. They mean the same thing to a lot of people. And what we mean by it's not used in medical settings, that if somebody goes to hospital presenting with a very advanced HIV infection and they have all sorts of symptoms, they won't be diagnosed with AIDS. They will say, you have pneumonia. This has been caused by your lowered immune system because of a HIV infection. We try and lessen the use in a modern context because of the treatment. AIDS isn't, and for me personally, it doesn't really make sense. It's not a syndrome, but it holds a lot of weight for people, especially in a historical context. And every person living with HIV will have their own opinion about whether they think AIDS is a good word to use or not. But as a service, we try and use it in a more historical context. So how does someone contract HIV? Again, I like to start off with the real basics when I do these trainings, because I think it's a really good opportunity to tell people the facts and also to debunk some myths as well. So firstly, we have vertical transmission from mother to baby through breastfeeding or the birth canal. Now, HIV is not transmitted through the sperm or the eggs. So if a mother is living with HIV, the baby is not guaranteed to be HIV positive. If the mum is on no HIV treatment, no antiretroviral therapy, it's around 30% chance of the baby being positive. And if the mother is on treatment and undetectable, in this country, I think the percentage is something about 0.007% chance of having babies born that are positive. Generally, if the mother is undetectable, the baby will be negative. That's certainly my experience when working in HIV for the last sort of 5 years that I've been working in this field. But that doesn't mean to say it still doesn't happen. You know, there are mothers out there who either don't get their treatment in time, who are unable to adhere to their treatment, but the occurrence is really very, very rare. Breastfeeding when somebody is on treatment still carries a very small, very, very low risk as well. And the current advice is if a HIV positive mum has a baby, the advice is to formula feed. So blood to blood, this is the one that often causes the most sort of conversations and questions. When I say blood to blood, I generally mean through blood transfusions or through sharing needles. When HIV is exposed to the air, it dies. It likes the very warm body environment. It needs a host to survive. It doesn't survive really outside of the body. So a lot of those fears around HIV and HIV transmission of, or what if someone bleeds on me, or what if it gets in my eye, or, you know, in my mouth or whatever. A lot of it is just fear, because to have a HIV transmission occur, there needs to be quantity of virus and quality of virus. So, for example, in a blood transfusion, there is quantity and there's quality because it's kept in a sterile, sealed container. Obviously, we have blood screenings in this country and pretty much all over the world now, but there obviously was a lot of people affected by the blood transfusions historically. Again, sharing needles is a risk, but it's quite a low risk now, especially when someone's undetectable. And it makes up a very small percentage of those who are living with HIV in general. And then the third way, or the main way that most people contract HIV is through penetrative, vaginal or anal sex. Oral sex is an extremely, extremely low risk of transmission. And what I mean by that, again, is if you think about transmission routes and the body parts involved, the sexual organs, you know, vagina and anal cavities, they are perfect for absorbing HIV virus. And elsewhere, so say oral sex, for example, it's a very, very low risk. There would have to be, for example, open bleeding wounds in the mouth of someone for there to be able to be a transmission risk through oral sex alone. As you may have read while I've been talking about someone being undetectable. So if a HIV positive person is on medication and undetectable, the virus is untransmittable. It means it cannot be passed on to sexual partners. I'm going to go into that in a little more detail as we go through. So I thought it'd be good to give you a little bit of a picture of what HIV looks like, the HIV picture in this country and in Leeds. So there are currently about 105,200 people living with HIV in the UK. We put estimated just because it is an estimation. We obviously have the people who are tested and who are in HIV care, but then there are a small percentage out there who are untested and are living with HIV unknowingly. So in Leeds, how that compares with Leeds, we've got about 1,350 people in care in Leeds. So those are people who are attending the clinic, who are known. Leeds does have a slightly high prevalence rate. of 2.77 per 1,000 in the large age range. It's slightly above the national average, and it's the highest in Yorkshire and the Humber area. Overall, about 6% of that 105,000 from the whole UK figures are thought to be unaware or undiagnosed. And when we are looking at strategies, these are the people we're trying to target, because people who are living with HIV, who know they have HIV, are not the ones who are passing HIV on. It's the people who are untested and undiagnosed. They're the ones who are unknowingly transmitting the virus to others. So of those diagnosed, we've got about 68,000 a male and 30,000 a female. And then we've got about 6,000, nearly 7,000 who identified as neither male or female or declined to answer. So in the Leeds area, how that looks, we have about 50-50 male to female ratio. These Leeds-based stats I've got off Public Health England and from the Brotherton Wing Clinic as well. They've given me a bit of an insight of what their patient cohort looks like. So again, nationally, we have about 94% of those living with HIV diagnosed, and 98 of that 94% are on treatment. Out of that, we have about 97% nationally who are undetectable. That means they are on their treatment and their virus is controlled. And as you can see, the Leeds comparison there is about 96.2% who are undetectable, so slightly lower than the national average. What that means, obviously, to be undetectable, if someone isn't undetectable, there are many different reasons why someone might not get there. It could be that they simply haven't got there yet. It can take anything between 6 weeks and 6 months for someone to become undetectable when they're on treatment. It could be that they have comorbidities and medications that interact and they just might not quite get there. It might be because they find it difficult to adhere to the medication and they can't take it as prescribed. So there are lots of different reasons why people might not get there through no fault of their own as well. So overall, in the UK, 89% of people are virally suppressed, meaning they're undetectable, meaning they can't pass that virus on to sexual partners, and they're also well and healthy. I thought I'd show a little bit of a breakdown. Now, these are national statistics because I think it paints a good picture of how prevalent HIV is in different communities. So as you can see, the Leeds split in ethnicity, again, they've provided me with the 50% Caucasian and 50% from other ethnic groups. Nationally, as you can see, the majority, over 50%, are white, with 28, nearly 29% Black African, and then smaller sections of other communities as well. I share this information again to debunk a bit of a myth. People often believe that HIV is a Black African problem. And as you can see, the vast majority in this country are white. You know, we are generally more white than any other race in this country, so it makes sense that it affects white people more. Same with the ages. When I've delivered this before, a lot of people are surprised to see that the vast majority of those living with HIV are between 35 and 64. It makes up for the main bulk of those that are living with HIV. We are an aging population. People who are diagnosed with HIV now, in general, are not dying from HIV. And they're living normal, long lives, just like everybody else. So this will present an issue over time of this aging population and how their HIV medication and care will be handled into those, those older ages, whether that's, through community nursing or care homes and things like that. And it's something that we as a service are looking into, of how we can train people in those areas to make sure that they are up to date on all this HIV knowledge and making sure that they have an accurate picture of what HIV is today, rather than their sources being an advert from the 80s. And then again, lastly, the mode of transmission. As you can see, again, the vast majority is through sexual contact, whether that's sex between two men or what they've labelled here as heterosexual contact, mainly same between a man and a woman. A very small percentage injecting drug use, so 1.9%. Other things that will be in there are your vertical transmission, so between mum to baby, and there might be some needle sharing or blood transfusions, or as we said, unknown. These statistics come from people saying how they contracted HIV. But as we said, for our purposes, the vast majority is through sex. If you're interested in statistics, these are all from the National AIDS Trust. You can go and they update them every year. Funnily enough, they didn't do them in 2020, so we don't have those statistics, like the full statistics just yet. I'm sure they'll come out at some point. I was quite surprised when I saw these. You know, I didn't think it happened to some of the different groups quite in these quite high numbers as that they are. So after someone has contracted HIV, they will often, as we said, go on to treatment. This is called antiretroviral therapy, or ART, or ARVs. Lots of people call them different things. It's a combination of 3 drugs which combat the HIV virus and keep it suppressed. For most people, it's 1 pill a day. Those 3 drugs will be combined into 1 pill, or some, you know, there'll be different variations of that as well. For the majority of people, they take it at one point in the day, even if it's, say, 3 different pills. The treatment is extremely effective. You could have had a very advanced HIV infection, and the treatment will be able to manage that HIV very, very well. So, for example, a lot of women, all women are screened in pregnancy, and they'll have a HIV test through their normal bloods in pregnancy. If they're found to be HIV positive, they can have that treatment and be undetectable. I knew someone who was undetectable within 3 weeks. You know, the treatment works so well for them. But we, in general, we'll say between 6 weeks and 6 months is how long that takes. What that actually means, being undetectable, is that there is less than 200 copies of the virus in the sample of blood that's taken. Once that is there, once the virus is so suppressed, when they have some sexual contact, it means it can't be transferred onto others. There is not enough virus to take hold in somebody else's body. And I just thought I'd add this in today. If anyone's been watching the news this morning, NICE have approved the long-lasting injectable medication to be offered to everyone, which is a really great stride in this, meaning that HIV positive people can go from having 1 pill a day to having an injection once a month. And I know that in Scotland, they've started rolling out the injections every other month as well. And you think about how far that treatment has come. If anyone has any knowledge on the history of HIV, when treatment first came out in the sort of mid to late 90s, people were on regimes of about 35 pills a day to be taken at certain times, and with massive side effects. And it was a real struggle on the body to just take the treatment. And it was often a choice between getting sick from the HIV or getting sick from the treatment. And over the years, this has just become a lot more refined. The medication that we take today has been available since sort of the early 2000s in a really similar format to how it is now. So I've said it loads and I am repeating myself, but if there's one thing you take about HIV today, is this: U equals U, undetectable equals untransmittable. So in 2017, the chair of the British HIV Association said the statement on there as the UK's leading voice for HIV health professionals, our backing for U equals U is unequivocal. This was really important because the undetectable equals untransmittable had been floating around as an idea since about 2008, when it was first presented as at a conference, and everyone was like, no, that can't be true. But then after years of study, mainly 2 massive studies called the Partner Study 1 and the Partner Study 2. The Partner Study 1 looked at thousands of couples where one person was HIV positive and one was negative. Both same-sex male couples and differently sexed couples as well. And they looked at hundreds of thousands of sexual interactions between these couples, and there wasn't a single HIV transmission. That was presented, and they said, yes, so U equals U is true for heterosexual couples, but they decided that there wasn't enough evidence for same-sex couples. So the partner study 2 was done, which focused solely on male-male couples. And again, there was zero transmission from someone who was undetectable to a negative person. What this means for the community, it's people would call it a game changer. It has changed people's lives. They've taken away the fear of transmission, that they can have a normal life with their partners. They can have a normal sex life with their partners. People can have babies without risk of transmission to the baby or to their partners, you know, through the sex that they're having. The treatment is about the wellness of the person, and their immune system is what they would call normal when on the treatment, and that's normal for whatever that individual's person's immune system was. And they will take on any other viruses or bacteria or whatever might come along, and their immune system will manage it just as well as if they didn't have HIV. And that is how effective the treatment is. U equals U is a fact. It's not an opinion or a discussion. It is a fact. HIV, we also do HIV prevention at Skyline. So I just thought I'd talk you through some different prevention methods. Now, this is the one that most people will know. When HIV was being studied in the 80s, they found that condoms were the best way of limiting HIV transmission. It's a barrier method, so technically it should be 100% effective. You know, there's a physical barrier stopping from any fluids being transferred. However, with condom use not being, you know, accurate a lot sometimes, you know, it's around 80%, you know, effective at stopping HIV transmission. And that is basically through not being able to use them properly or ineffectively. You know, if people don't put them on right, if they're using the wrong size, if they break, you know, there's all these different things that might happen. But it's usually user error as to why they don't work as well as they should. So that's why it is important to teach people how to use condoms effectively, making sure they have the right lubricant that works well with their condoms, so it won't lead to corrosion or anything like that. And obviously, they have the added benefit of protecting you from other STIs and pregnancies as well. So very effective, but as we know, most people, they don't like to use them, and they continue not to use them in both male-male couples and then also in the heterosexual community. And some of the work that we do is talking about, you know, why we use condoms. We're not going to sell a lie that it doesn't feel any different, like the lie I was told when I was at school. But we talk about the importance of using them and why we do it. Why, yes, it will be different, but it can be part of a real exciting sexual experience. It doesn't have to limit the sexual experience using a condom. So then we have PrEP. PrEP is something that has been around for a little while. It has been available in Wales and Scotland for a long time on the NHS. England came a bit later, and it was only last year when it was able to be prescribed to everyone. So PrEP is, again, a daily pill. It's actually made up of two of the same drugs that HIV positive people are on, and it's shown to stop the HIV from taking host in a body. So for women, they would have to take it every day for it to be effective. Men can take event-based dosing, meaning if they know they're going to be having sex, say if they're going on holiday, for example, or they know they've got it at the weekend and they might not be using condoms, they can take it before the event, during the event, and then after the event. The reasons of why that is, it's just different bodies. It's the difference between the anal cavity and the vaginal cavity, and the way that the PrEP is absorbed into the system, the way that HIV is absorbed into the system is the difference that it makes. Similar to the contraceptive pill, it's around 99% effective when taken correctly. But like on any medication, it does have a few side effects. People who choose to go on it have to have their kidneys and livers monitored. It's very underused, PrEP. It's very well known generally in the gay and bisexual male community. It would be amazing for those people who are at high risk in other communities to be more aware of it and the benefit it can have. And now it is available for free to anybody who wants it, you know, on the NHS. It's something that we are promoting within the communities that we work in. And if it's something that you ever hear about in conversation, you know, it is a very effective tool, very effective. And similarly, sorry, has anyone got any questions about PrEP?
I do, Becky. When you say it prevents transmission, who takes it? Is it does it prevent transmission if you know you're HIV positive and you take it, it stops you from giving it to somebody else potentially, or the other way around, or both?
So PrEP is for HIV negative people to take.
Okay, cool.
You have to make sure you have a HIV test before you're prescribed it. They need to make sure that they are negative before they take it. So it's for your personal health as to why you might take it. It's so you don't get HIV from somebody else. People who are already living with HIV, they can stop the transmission forwards by taking their antiretroviral treatment.
Yeah, lovely. Thank you.
Thank you, Becky. I've just seen in the chat there. What effect does it have on the kidneys and livers? Again, it will depend from person to person as to what effect it has. For most people, there won't be any effect, but they just monitor it because, like any medication that you're taking, so it can just cause problems and damage down the line. So it probably wouldn't cause any issues for somebody who might be taking it for short periods of time. Longer term use is what they're monitoring for, really. In terms of what exactly they do, I'm not entirely sure as to what problems it can cause, but that's why it's monitored. And I know that they do a check before somebody starts on PrEP and to check their kidney and liver functions and making sure that they're all working okay before they give it them to make sure that they're safe. Someone said, what does PrEP stand for? It's a pre-exposure prophylaxis, which just means it's taken before the event to stop the transmission. As well as PrEP, we have PEP. And then the question there was, what does PrEP stand for? Well, this is PEP, so this is post-exposure prophylaxis, meaning it's taken afterwards. So it's a course of medication that can be taken within 72 hours of a sexual encounter. I've put sexual encounter, but it also could be, for example, a needle stick injury. People might choose to take PEP after that. With someone who was living with HIV but was not on treatment. It has to be taken for 28 days or a month after, from the first pill to stop the HIV, taking host in the body. PEP can be available through A&E, through sexual health clinics. PEP is often given to rape crisis as well. A lot of the time, people will ask for PEP if they're unsure of someone's status, or, for example, maybe if they've decided to use a condom, if someone was HIV positive but not on treatment and the condom broke or didn't work effectively for whatever reason, and then they might choose to go on PEP to stop that from taking hold. It is hard to know exactly how effective it is, but again, it's been around for a long time, and it worked. As far as we know, it works really, really well to stop people contracting HIV. Next form of HIV prevention is regular testing. Everyone should know their status and have an HIV test. That is, every single person should have that. I think there's a lot of issue, or people think about HIV and they think maybe if they're asked for a test that a doctor or nurse or healthcare professional is presuming something about them, when they won't be. It's simply a test. When you break down HIV and you remove all the stigmas that surround it, it is just a virus, the same as any other virus out there. One that can really damage your immune system, and if left untreated, it can leave permanent damage to your body if you get some infections. So everyone should be having a HIV test at least once in their life. We say people who are sexually active with different partners should be tested a minimum of every 3 months. It can take up to about 12 weeks for a HIV infection to show up in a test after a sexual encounter. It would normally start to present a bit sooner than 3 months, but we say the 12 weeks there is what we call the window period. So if, for example, someone had a sexual encounter with someone, they were worried that they might have contracted HIV, we do get people come into our offices to test like this, and they tell us that the interaction happened maybe a week before. Our test wouldn't be able to pick up that if it only happened a week before. Often we will still test them there and then because it gives people peace of mind. And then we ask them to return in 12 weeks or 11 weeks afterwards. I've put someone here saying A&E is not testing for HIV routinely anymore, but acute medicine inpatients are routinely tested at St. James. That's good to know. Thank you. Yeah, I didn't know that had changed for the A&E. I thought that was the same. So what does the test consist of? So the test, it depends on what type of test you're having. You can have either a finger prick rapid test, which looks similar to the picture there. There are lots of different brands out there. And they will give you answers in anything from a minute or two up to about 15 minutes. Or you can have an intravenous blood test, which is done at sexual health clinics or nursing or GPs or wherever it might be. I've put the list of there where you can test in Leeds. Community testing, so out in venues and community venues are often the finger prick rapid test. And we test for the antibodies of HIV, which is why we have that 12-week window period, rather than the intravenous, I think, can pick up HIV up to about 4 weeks after an infection. So we might advise somebody, if they're in that window period, to go to, say, the Merrion Centre and have an intravenous test done. Like I said, there are lots of different ways to get tested. Testing opportunities are often missed. For example, I know a service user that was in and out of hospital for about 2 years, an older person in their late 50s who didn't fit into the box of a man who has sex with men or a Black African person. And they were presenting very, very typical HIV symptoms. And then, like I said, in and out of hospital for 2 years before somebody thought to do a HIV test. So we really do want to encourage regular testing in all communities, because we do have that 6%, and the 6% are usually the ones who are unknowingly spreading HIV around. Well, one of the things I think I didn't say, so the rapid tests that are done in community settings, the finger prick tests, you do get the results instantly. And the intravenous test will take a few days to come back. Similar to any other STI testing, people will usually get a text message saying their results are all clear. If their results are, if they do get a reactive HIV test result, they'll often be called to come back in and for retesting and to be told that news as well. And the results are usually given within 3 days to a week generally. Another thing I'd like to talk about here, so we've talked about what HIV is, how it's transmitted and how it isn't transmitted. And we've talked about prevention tools and testing. But the main bulk of the issues that surround HIV is the stigma. Now, one of the things I put up on the blurb for this is about calling HIV the other pandemic, because by definition, HIV was a pandemic. It spread all around the world and it affected all communities. though at the time in the 80s, HIV was othered. It was seen as some sort of moral standing. You know, if you had to have done something morally wrong to have contracted it, and that was your fault. You know, that was the person's fault, and they almost deserved to suffer in shame and silence. As somebody who, although I was alive in the 80s, I didn't consciously, I wasn't aware of what was going on as I was young. As speaking to people who I've met who lived through that and have a memory of the HIV, especially those in the gay community, that is the perception that they were given, and that the world, how they saw HIV as well. And these are the sorts of things you saw. God's wrath of the gay people, gays in fear, they dread revenge, AIDS blood to 18 people, because it's painting the picture that people living with AIDS are wrong, that they're vindictive, that they're out to get other people and infect them. Gay plague, curb on AIDS peril. Obviously, these are all from newspapers at the time. I often wonder how it would have been perceived in today's media, and the comparisons that we can draw from how HIV was portrayed by the media as to how COVID has been portrayed by the media. Gays conspired to infect society. Oh, yes. Call for homosexuals to spot gay clients. Because apparently in the 80s, if someone was gay, you could obviously tell just by looking at them. So these are some really powerful pictures that came from a very famous photographer in the late 80s, early 90s, who humanized HIV for a lot of people. The patient in the bed there, you know, very thin and emaciated, that's his father and his mother and I think his sister. And that person was a very large man, about the same size as his father and his mother. And the virus just wasted him away. Again, same patient. Then you might recognize here the lesions, skin lesions that people used to get. And this is generally how people perceive HIV. And unfortunately, they still perceive it to be like this today. A lot of where it's like the general public's knowledge on HIV is vastly, very outdated, very outdated. And then you'd remember this, the AIDS advert. I'm somebody who voluntarily has gone onto local news and radio and talked about my HIV status as a HIV positive person and what it's like to live with HIV today. And yet every time I do anything, they always manage to slip in this little AIDS commercial. For, you know, they'll pay 2-3 seconds of it, but it's always there and it's still there, even for people who weren't even alive when they were running on TV. It's most people's knowledge and of how that sort of fear that was created. The thing is, this fear mongering, it kind of worked. Transmissions went down a bit. People lived in fear and people were ostracized and people were demonized because they might have had HIV, but, you know, it made everyone aware of it. Sadly, things haven't really changed very much. This news article, as you can see there, is from 2017. Woman has been jailed for spitting in police officer's mouth, telling him she was HIV positive. Now, I read this news story. I went further than the headline and I read it. And she wasn't arrested for that specifically. She wasn't jailed for that. She was jailed for a number of different things: assault, damage of property. She damaged a police car, property. She'd been on parole for a while and all of that. So, but that's what the headline they chose to go with. HIV has never been able to be transmitted through spit. That's just an urban myth. The virus, there is not enough virus in spit ever for anyone to be able to transmit it that way. But the way they choose to report it is, again, the same old trope of HIV people are crazy, vindictive, and out to get other people. Then you have things such as the Daily Mail or the Daily Fail. The NHS told to give out 5,000 a year lifestyle drug. They're referring to PrEP here, to prevent HIV, as vital cataract surgery was rationed. Obviously, they're trying to pitch HIV against other conditions, saying like it's a choice, like they choose to fund one or the other. And describing it as a lifestyle drug, again, is just saying that HIV is a choice for people when HIV is not a choice. HIV is contracted through a very normal human interaction. We do have some good stories. Some of you may have heard about Gareth Thomas, who was the Welsh rugby captain and is involved in a lot of TV presenting about rugby as well, when he came out as HIV positive. Here we have a really positive story of someone living with HIV who is well and healthy and extremely fit. The day after the day this came out, he was doing an Ironman. But this here is what people remember. This is what people living with HIV deal with every day. It is wonderful when we have stories like Gareth Thomas coming out. But one story, unfortunately, doesn't undo all of those years and years of built up stigma that HIV positive people carry around with them. I noticed a question that the AIDS advert, someone said they weren't familiar with it. So it came out, I think it was 1986 was the first one. It said things like, the AIDS virus is coming, and be aware and make sure you're not putting yourself at risk. And the AIDS was there on a big black tombstone, and it fell down and went, and there was ones with a Grim Reaper in it, and they were very, very scaremongering. So I thought I'd talk about HIV in the law, because when we talk about HIV stigma, it is linked in with the law and what laws there are around it. Now, people living with HIV are protected under the Disability Discrimination Act. So it does mean it's illegal for anyone to share, to be discriminated against because of their status. It's illegal to share someone's status without their consent. It's illegal to refuse employment. There's only one job, which is frontline defence in the armed forces, where you can't have that job if you're HIV positive. Some jobs do have conditions if you're living with HIV. For example, usually healthcare situations, they say generally if your hands are ever going to be going inside someone else's body, so anyone who draws blood, anyone who's a surgeon, those sorts of invasive things, they can still do the job, but they just need to be on their medication, undetectable, and they're tested every 3 months instead of the every 6 months to a year that the general public said. So HIV, somebody living with HIV, like I said, the medication is so good and so effective. It has little to no side effects. I've been on this medication since 2015, and I've never had any side effects, and the vast majority of people don't. You're not signed off with disability anymore if you contract HIV. I thought I rang up my life insurance people and thought, I might be able to get a payout, but no, you're not allowed anything. But that doesn't mean you're still not discriminated against, because it's very hard for me to get life insurance now I have it, even though medically it's the same as any other long-term condition. Just because it is protected and it is against the law to be discriminated because of it, that doesn't mean it doesn't still happen. So in the last 5 years, I've met people who have lost their job because of their HIV status. Managers have told other employees. People I know have been blackmailed, sexually assaulted, physically assaulted, refused to be even allowed to apply for a job, refused chiropody appointments, refused dental work, put last in the operation schedule, so making sure that their operation was last in the day. That happens a lot, and it's an extremely outdated situation. And if that ever happened to me, my challenge would be, well, what are you doing in your operating room, which means it isn't clean? Because I don't think I want to be operated on at all if you're worried about, transmission between operations. I know people have been refused tattoos, piercings, and beauty treatments. People have had their home vandalised. I know someone who was accused of transmitting HIV to someone, and they were handcuffed on their front doorstep and taken to a police station and questioned and treated like a criminal, when that person who that happened to was undetectable and on treatment, and a transmission could not have occurred. And once they were in the police station, the police spoke to their doctor. The doctor said that information, they got to go home. However, that's traumatizing. That's traumatizing for them. That's traumatizing because they know everyone on their street knows that they were arrested for something that was prevented. And that's due to the police's sort of lack of information about how HIV is today. So just because it's against the law doesn't mean it doesn't happen, and it happens frequently. And a lot of the time, people don't feel they can challenge this. You know, obviously it is illegal for a manager to tell someone else's HIV status. However, people who it happens to often don't feel that they can challenge it. And this is where we come in. You know, if they come in and tell us about this, then we're able to support them with their complaint, with their challenges. And we have seen them through. Just like people losing their jobs, you know, it's very discreet discrimination, and it reminds me of when people talk about racism and how it won't be overt racism on, you know, there'll be another reason why they decided to let somebody go or refuse them for promotion, but they know it's because of their HIV status, and they just know that, but they'll find another way around it. The discrimination happens all the time. And we work to deliver trainings to, like I said, these services, third sector services, public and private businesses, just so we can just give people the knowledge to so that there's no reason for anyone to be discriminated against because of their HIV status. So what can I do, or what can we do to sort of lessen this discrimination? I've put it both in a public, in your work setting, and a sort of a private setting, making sure that if somebody does talk about their HIV status, they've told you because they trust you, and they're trusting you to keep that information to yourself. For people to understand that is no one else's business, their HIV status. No HIV positive person is under any obligation to tell anyone about their HIV status. So it doesn't really matter what the setting is. They don't have to legally share that, apart from those employment situations where I've already stated it. So nobody has the right to know about it. It's a personal choice. I choose to be public about it because there are people who live in fear of being ostracized by their community, fear of rejection, fear of losing their jobs. So I tell my story. So hopefully it gives other people hope that they can live a normal life. If you are a manager and you learn of someone's HIV status because of their, it's on their employment forms, please just treat it like any other long-term medical condition. Most people won't need many appointments, you know, a year, but just, again, it's private medical information. Challenge negative stereotypes if you hear them. It's not a gay disease. It doesn't only affect African communities. And then also share your knowledge. You know, hopefully you've learned some really good things today. And tell people about you, because you tell people about PrEP, because it's the only way this discrimination is going to lessen, is when the general public's knowledge is increased about HIV. So a little bit about what we do. We offer all of these different things. We work in partnership with Live Well Leeds as well. We work in partnership with Touchstone as well to really raise people's knowledge and awareness. We offer support to all people living with HIV. We have groups, we have support groups, health and wellbeing groups. We have cognitive behavioural therapy, massage therapies. We offer peer mentoring. This is a really good service, one that is probably one of the most beneficial. Talking to someone else living with HIV is probably the number one way people talk about improvements in their mental health. We offer rapid HIV testing, both in our offices and out in community settings. We have HIV and STI prevention sessions. That can be with one-on-ones, or it can be group sessions in people's workplaces, people's services, and then trainings similar to this, HIV knowledge and awareness trainings as well. A little bit more about what you could do. What can you do to sort of support raising people's knowledge and lessening discrimination in HIV? Just a few ideas there. Normalising you equals you by talking about it, talking about personal sexual health in general. Normalise HIV testing. If you've never had a HIV test, have one. Find out, know your status, and tell people about it, about how normal it is, how it's the same as any other blood test. At least now you know, at least now you have a baseline to go from. Challenge misinformation. You know, there is a lot of misinformation out there. And I've put AIDS jokes because I still hear them. I still hear people make a joke of it. And it's not right. If you've got an office space, put you equals you posters around, have literature available, show our information about Skyline. And support the standardised opportunistic HIV testing for everyone. We're hoping to get this when you register for a GP to have HIV testing. It's a long road out for that, but we know it works. For example, like we said about screening in pregnancies, the reason transmissions are so low is because everyone is screened. If everyone was going to be tested, then we'd find that 6% easy. It goes into a lot more complications of who's going to fund that and how's it going to be rolled out. But there is a global scheme of zero HIV transmissions by 2030. And as we've learned, HIV is completely preventable with PrEP and PEP and condoms. It's completely treatable with ARVs. And when people are on treatment, they live a normal, healthy life, or what's normal for them. And they can't pass it on to other people. And these are the things that we need to sort of get out there. One of the things I like to say is to put a positive sort of side on things. There is no negative result from a HIV test, because you either find out that you don't have HIV, and that's great, and you can carry on your life and practice your prevention techniques, or you find out you do have it and you can get your treatment, which is for most very easily managed. So it is always beneficial to have that test. I hopefully have debunked a few myths today. You can't tell if someone has HIV. All of those people in those pictures at the bottom have HIV. And they're all different. They've all got different backgrounds. They're all different ages, different genders, different sexualities. And they all live well with HIV. So I just thought I would let you know about some events that we have going on. So like I talked about World AIDS Day, we are having a celebration and remembrance event at the Civic Hall from 6 p.m. on Thursday the 2nd. World AIDS Day is on the 1st. On the 1st, we are trying to gather on the steps outside Leeds City Town Hall for a minute's silence at 11. If you're unable to get there, we say try and take a bit of time during that day to just remember. It's over 33 million people that have died from HIV. And in 2020, that was 680,000 people died, because of their HIV infection. And when all of those things are completely preventable and treatable, that was globally, by the way, there's no reason why this should be happening anymore. No reason at all. So try and take some time, like I said, to try to remember those people that have lost, and that people still struggle to and live in isolation because of their HIV infection. And there we go. And that's everything from me. If you'd like us to deliver training for you or anyone, please do get in touch. That's my email address there. The slides are going to be sent out to everyone who's joined today as well. Thank you for coming to this, and I hope that my information I'm giving is accurate. And if I have made any mistakes because people have got a little bit more knowledge than me, then please share it, because I don't want to be spreading any misinformation or anything that's wrong. Yeah, but other than that, that's it, everyone. So Catherine's saying there's a blame culture Yeah, exactly. There is very much a blame culture when it comes to HIV. We really try and work against the narrative of that. You know, HIV is a virus and it will be passed around through human contact. Sexual contact is human contact. It's very normal human contact that most people will do in their lives. One of the things I was told about living with HIV said, "Oh, were you promiscuous or were you just unlucky?" And I was like, well, everyone who ever has contracted HIV is unlucky, and one person's normal is another person's risky. So who are they to then judge how people are? But that's my session finished. So thank you for listening today, and I hope you were able to learn something along the way. Thank you.